So, good
Yeah,
evening, all the respected delegates.
Good
Myself,
evening.
Amar Sahu, RSM at Vijayawada for Pharmacare Division of Sun Pharma, makers of Cepodim and Montec Effects. At the outset, let me wish a very good evening to all our esteemed panel members and audience. Sun Pharma,
Good
being a
evening.
number one pharmacy company in India, always wants to associate and contribute various scientific programs. And in the past, also, we had conducted several live surgical workshops as well as webinars to facilitate the knowledge of sharing program. We are committed to do so in future. At Sun Pharma, we feel extremely proud to associate with such an eminent group of speakers audience from across the country. And we feel extremely happy to continue a series of webinars which we are conducting every month on behalf of AYAP branch. This is the 31st series of webinar, and the main objective of this series of webinar to concentrate on basics and which will be useful especially for young ENT surgeons and ENT PGs. So in this series, we will have eminent speakers. So today's topic is there's a PG case presentation, short case by Dr. A. Sachita, that is junior assistant, your case at the Koti ENT hospital. And today's examiner, Dr. Kevin D. Prasad, Professor ENT, Hyderabad. I think he's right now is absent. Dr. Azim, Professor ENT, Kolar, and Dr. Anthony Francis, Professor ENT, Chennai. And sir, without as well as I welcome all examiners of today's case presentation. Also welcome Deputy sir for coordinating today's program, sir. So I also welcome all esteemed committee member of AYAP State, sir. So now, without taking much time, I am handovering session to Jayaprakash sir to formally introduce our eminent examiner and take the proceeding of today's program, right, sir. Sir, over to you, sir.
good evening, everyone.
Good evening, Dr. JP.
I would like to thank all the examiners for taking the time and joining us with us. The idea
Thank
of keeping this program for today is because the exams are fast approaching for the postgraduates. Probably they will be in the month of December or January. That is the last month we had a long case discussion about the ear surgery, cholesteatoma. Then this time we have 4 cases and we have 3 examiners. One from Kolar, he is Dr. Azim. You all know him. He doesn't require any introduction. He's senior most ENT surgeon with a special interest on head and neck surgery and a well-known teacher across India. So I welcome you, sir. Then another
Thank you,
examiner
sir.
is Dr. Francis. He is from Chennai. He's working in Madras Medical College for many years. He is an accomplished teacher. And we have KVND Prasad, Durga Prasad. He is working as associate professor in Koti ENT Hospital. And he has got vast experience in conducting his programs and many teaching programs. So we have 4 cases today. That is 2 PGs from Koti ENT Hospital, one from NRA Medical College, Vijayawada, and the other one is from Tirupati. So now, without wasting much time, we'll ask the first PG to take the...
Sure.
Yeah.
Thank you, Dr. JP.
Thank you, sir.
Good evening, sir. Is my screen visible?
Yeah. You're
Yeah.
visible. Good evening.
Yeah.
I'm presenting a nose case. A 55-year-old male, Venkanna, resident of Miryalguda and farmer by occupation, came with chief complaint of left-sided nasal obstruction for 6 months. History of presenting illness, left-sided nasal obstruction, insidious in onset, gradually progressive, initially partial, now complete, continuous throughout the day, no diurnal or postural variations associated with breathing, no aggravating and relieving. History of nasal discharge, insidious in onset, gradually progressive, mucoid in consistency, moderate in amount, non-foul smelling, occasionally blood-stained, no aggravating and relieving factors. History of bleeding from left nasal cavity upon manipulation, 1 episode, scanty, 2 to 3 drops, subsided on its own. There's no history of snoring, no history of frequent throat clearing, no history of headache and facial pain, no history of disturbances in smell, no history of trauma to nose, no history of sneezing, itching, and watering from eyes. There's no history of change in voice, no history of facial swelling, no history of facial numbness, no history of visual disturbances, drooping of eyelids, protrusion of eye, no history of difficulty in opening mouth, no history of loosening of teeth, no history of swellings over the neck, no history of fever, cough, and night sweats. There's history of loss of appetite and loss of weight, no history of ear and throat complaints. Past history, no history of similar complaints in the past, no history of hypertension, diabetes mellitus, thyroid disorders, heart diseases, epilepsy, bronchial asthma, pulmonary tuberculosis, blood transfusions, and drug allergies. There's no history of ear, nose, and throat surgeries in the past. Family history, not significant. Personal history, takes mixed diet, disturbed sleep, and decreased appetite.
You are presenting short case, isn't it?
Yes.
So no need to go into all these details. Fine, you presented your relevant history in a nice way.
Yes.
No need to go into personal history unless there's something. Any addiction?
Yes, sir. History of occasional alcohol intake for 30 years and history of cigarette smoking, 20 pack years.
Okay.
Yeah. Go ahead.
General
Go ahead.
examination is normal, sir. Systemic examination is normal. Ear, nose, throat examination, nose examination, examination of face and orbit normal, external framework of nose normal. On tip rising, columella is normal, vestibule on right and left nasal cavity is normal. On anterior rhinoscopy, right nasal cavity, nasal mucosa is pink, floor is normal, roof normal, lateral wall is normal, septum, there is mild deviation to the right. Left side, nasal mucosa is pink. There is slough-covered red also proliferative growth seen in left nasal cavity, extending anteriorly up to inferior turbinate. On probing, yes, sir. Yes, sir.
Yeah, characterize the growth. You said it's in the left nasal cavity right up to the middle turbinate. Is it filling the...
It is filling the entire nasal cavity up to the inferior turbinate, sir. Inferior turbinate as such is not visible.
Okay. Yeah.
What's the appearance? What's the appearance of the growth?
Sir, it is a slough-covered proliferative growth.
Okay. You said ulceroproliferative. Is it ulcerating the adjoining mucosa or septum, or you said turbinate is healthy?
So there is a
is it a polypoid mass?
Slough seen on the superior part of the mass, sir. So I assume there is underlying ulceration over the mass.
Okay. Please continue with your probe test.
Yes. On probing, the mass is friable, firm, bleeding on touch, non-tender, irregular margins. Probe could be passed all around except laterally. Posterior rhinoscopy, pinkish mass is seen occupying the nasopharynx area, obscuring view of both the eustachian tube openings and the walls of the nasopharynx. Paranasal sinus, no tenderness elicited. Functional test, smell is normal. Cotton wool test, decreased movement of the left side. Whole spatula test, there is absent misting on the left side with decreased misting on right side. Cottle's test is negative. Oral cavity and oropharynx are normal. Indirect laryngoscopic examination is normal.
Why did you do a Cottle test here?
Sir, because the mass is seen extending up to the inferior turbinate to see the patency of the internal nasal valve.
See, this nasal valve comes into picture when you have a deviated nasal septum.
Yes.
Okay. When the mass is filling it,
yes,
there's no point doing Cottle's test. It's blocked.
yes.
Okay. Yeah.
Perhaps Cottle test is for completion in this sake, because like Sir is saying, when there is already a mass occupying it, when you move it, if there is deviation, if you can create the space, that is going to tell us something about the outcome of the surgery. Whereas when a mass is filling, it won't be relevant. But for completion's sake, okay, right.
Yes.
Yeah.
Oral cavity oropharynx is normal. Indirect laryngoscopic examination is normal. Ear examination is normal.
Did you check for the sensation over the infraorbital region?
Yes, sir. In my cranial nerve examination, I checked for sensation of the cheek area.
No, not cranial nerve examination. I'm asking you direct question because you said the mass is filling the nasal cavity.
Yes,
and
sir.
we don't know the status of the paranasal sinuses.
Yes.
So is the infraorbital nerve involved there? That's what I would like to know. Is it
No,
extending into the antrum? We still don't know.
Yes, sir.
Specifically,
Clinically,
sensation in
sensation-
infraorbital region. Specifically, sensation in infraorbital region, Sir is asking.
Sensation in the infraorbital region is preserved, sir.
Okay, you
There
checked
is
it?
no numbness. Yes.
Okay.
Any condition recently of an epidemic where there were paresthesiae over cheek, what you should suspect immediately?
History of COVID infection.
No, paresthesia over cheek, an immunocompromised individual post-corona, something like that.
Mucormycosis.
Okay, right.
Yes.
Yes, good. Go ahead.
Cranial nerve examination is normal, sir.
Okay.
Neck examination, trachea is in midline, no swelling, sinuses and scars noted, no palpable lymph nodes, bilateral carotid pulsations felt. My provisional diagnosis is left sinonasal mass, probably malignancy, clinically T2, N0MX, stage 2.
What do you say, T2?
Sir, because the mass is extending through the middle meatus into the nasal cavity.
No, that's okay. Is the infrastructure involved? Is the suprastructure involved? What is this line dividing the infra and suprastructures?
Ongren's line, sir.
Okay, what's that line?
It is extended from the medial canthus of eye to the angle of the mandible. Suprastructure, suprastructure has a poor prognosis, while infrastructure has a good prognosis.
So here we don't know the upper limit, isn't it? You are saying it's filling the nasal cavity. In fact, it's going into nasopharynx.
Yes, sir, extending into the nasopharynx.
Okay.
Sir is asking a
And
relevant question. You don't know its extension above superiorly into the nasopharynx. Can
Yes.
you do any investigation or a clinical examination that by which you can say it has not gone into the nasopharynx or it has not eroded tissues into the nasopharynx? How to know that clinically? I don't want a CT scan or MRI here.
Cranial nerve examination, sir, because
Anything else clinically? Suppose you put a scope.
diagnostic nasal endoscopy.
It is
We
not
can-
allowing you to, on the right side, the mass is there. It is not allowing your scope to go on that side.
So I would like to go through the opposite side and see the extension of the mass in the choana.
Okay. What are all the things? What are all the things you see? Suppose on the opposite side, you have gone into the choana with a cotton bud or a kuchi or whatever it is. You are trying to do a probe test. What are all the things that you would like to see on the opposite side? You have gone up to the nasopharynx from the opposite side.
Yes, sir. I
What
would
would
like
you like to see?
the
What
mobility
would you like to
mass,
examine?
superiorly and posteriorly, so that to know whether if I couldn't able to pass the scope posteriorly, then the origin of the mass could be from the nasopharynx.
Okay. So that's how you knew it. This is the mass extending into the nasopharynx and not coming from the nasopharynx. Is that what you want to conclude by the clinical examination?
Yes.
Yes. Sir, welcome, Dr. Anthony Francis, sir. Good evening.
Sorry, sir. We had a cadaver dissection workshop today. We had a it got over very late, so I am joining little late, sir. Sorry.
No problem, sir. Honored to be with you and Dr. Azim.
thank you, sir.
Welcome, sir. Welcome, sir. Yes.
Welcome, Dr.
Good in the
Francis.
sir.
Yes, sir. Yeah. Sir Azim,
So-
sir, please go ahead.
Yes, sir. So what are your points against this being a nasopharyngeal mass? I agree with you. This is not from nasopharynx.
Yes.
Can you highlight few points to show that it is not from nasopharynx?
So usually, nasopharyngeal mass spreads laterally towards the parapharyngeal space or superiorly towards the skull base. Its extension into the
Why does it
cavity
go
is
to
very-
parapharyngeal space?
So because of its close proximity, the
What do you understand by nasopharyngeal recess?
So nasopharyngeal recess is the fossa of the Rosenmuller, sir. Lateral
So
lesion.
that can extend up to 1.5 centimeters. It has no resistance there. Okay.
Yes.
What is sinus
Right.
of Morgagni?
Yes.
Sinus of
Sir is
Morgagni
asking sinus of Morgagni. Yes.
space between the base of the skull and the superior constrictor muscle.
What are
Okay.
the structures passing through it?
Tensor palatini, ascending pharyngeal artery, emissary vein.
Next question will be, what is the origin of tensor palatii?
And any nasopharyngeal malignancy, the most common presentation is cervical lymphadenopathy,
Yes, sir.
followed by torrential epistaxis. These are the most common presentations. What do you understand by Trotter's triad?
Trotter's triad is characterized by soft palate palsy, conductive hearing loss due to eustachian.
It's actually not palsy. This is the
Fixity.
misconcept. It's unilateral fixity. To go to a palatal palsy, it should be a highly advanced lesion. Okay.
Yes.
What's the innervation, motor innervation of soft palate? It's vagus.
Vagus.
So unless it's near the brain stem or near the jugular foramen and erodes it, it will not cause a palsy. It's usually unilateral fixity. Okay, then the other two components.
Conductive hearing loss due to eustachian tube.
Yes. Due to
Temporoparietal.
secondary otitis media. Okay, then
Then temporoparietal neuralgia.
okay.
What is Jacquard's triad?
Sir.
What is Jacquard's triad?
Jacquard's triad.
Jacquard syndrome, orbital apex syndrome.
Amaurosis fugax, trigeminal neuralgia, ophthalmoplegia. That is Jacquard's triad. That's a the orbital apex syndrome. Okay, that is also common in nasopharyngeal carcinoma.
What is Marcus Gunn pupil?
Marcus Gunn pupil is relative.
It's when the ipsilateral optic nerve is involved. Since we went to orbital apex, I'm asking you. There will be absence of afferents on the affected side, whereas afferents are normal on opposite side. So when you look for pupillary reflex, when you shine the light into the affected eye, there will be no response. When you shine it on the other eye, consensual light reflex will be present. That is Marcus Gunn pupil. Okay, continue.
Because specifically afferents are involved.
Yeah.
Afferents are involved. That's what sir is.
Yeah.
Right. Okay. Okay.
Continue.
Continue.
You are
So
doing
you
a
have a-
diagnosis. Any differential diagnosis do you have? Because
Yes.
when you say mass in the nasal cavity, it's a very wide thing. And you
Yes.
said probably malignant.
Yes.
So can you think of any specific diagnosis?
Let us say you are saying malignant because of the clinical examination. Let us say a mass in general in the nasal cavity. You are saying coming from the lateral wall of the neck. You can also consider benign and malignant. Both. Can you tell the differential diagnosis?
Yes. Like simple hypertrophied inferior turbinate.
No, that's too far-fetched. You said the terminate is normal. When you said it, I believed it.
So in this case,
That's a classical teaching we make while teaching
Yeah.
polyps, sir. So she's telling that. Okay. But you mentioned it normal. You mentioned it normal in the examination. So exclude that and go ahead. Next.
antrochoanal polyps.
Antrochoanal. Okay, then. Unless it's
Metaplasia.
metaplasia and all. Okay, then.
It's not pale, it is congested. Why? Suppose you say it's antrochoanal polyp and sir agrees. Why it is pinkish?
Due to angiomatous changes.
Why not squamous metaplasia
Could be squamous metaplasia.
with inflammation?
Yes.
Yes.
Okay.
Okay, next.
Then,
Next.
Rhinosporidiosis.
okay.
Only
Take it with a salt. Yeah.
Sporiosis arises from the generally rhinosporiosis is a classical description occurs in the spur or the septum. But rhinosporium is the good differential diagnosis. Then
Okay, then
Allergic fungal rhinosinusitis.
no, that won't look like
again it'll come back to a polyp with metaplasia. Then
Inverted
Pale
Ah.
edematous mucosa is characteristic of allergic rhinitis. We are describing a pinkish mass with a slough on the surface. So allergic rhinitis won't really come near that. You said rhinosporidium. For interest's sake, I'm asking, who discovered rhinosporidiosis and in which country?
actually two people always on the same time.
Yes. Lesser known species of rhinosporidium was the first man, Kilineyi. It was in South India only. Okay, go ahead. Okay, right. Rhinosporidiosis. How does it appear characteristic? Grass appearance.
reddish granular surface. The surface started with the
Before you said it, before you come to surface, you should mention it is a sessile polypoid mass. Okay. Classical leafy appearance.
Yes.
Then you come to
leafy appearance, pinkish mass, leafy appearance with dots, whitish dots on the surface, which is sporadic. Okay.
you said inverted papilloma.
Inverted papilloma.
What's in favor of that?
Inverted papilloma with the malignant transformation.
What do you say, malignant transformation?
Because gross appearance of the growth, it is slough covered and also proliferated.
Even inverted papilloma can be
Inverted
slough covered.
It usually has a pale polypoidal.
No, not always. Not always. See, what polypoid masses you see may not be actual inverted papilloma. Okay? What is Bernoulli phenomenon?
Due to any constriction, there is the airflow, there is
Yes.
pressure drop.
So
And
even a benign tumor near the ostium can do that. Producing polypi. Whenever you find unilateral multiple polypi, always rule out a mass. Okay?
Exactly. Underlying malignancy, sir. Many times I have seen that underlying malignancy. You can simply tell it PV is equal to K. Pressure into velocity is a constant. So when the velocity increases because of the narrow space, pressure drops, and that's how polyp is pulled. We had a case outside, sir. She happened to be mother of sub-editor of a journal, press.
Yeah.
And we luckily in the last minute, we stopped ourselves from plucking out the polyp, which turned out to be a squamous cell carcinoma. That's what sir is saying.
What are the chances of malignant transformation in inverted papilloma?
There is 5 to 15% of chances of conversion.
5 to 15% without radiation. When you radiate them, it increases. Okay.
Why is it called inverted papilloma?
Because it is an endophytic growth. The surface epithelium grows inversely into the connective tissue stone.
It's not just epithelium.
What is a Ringer tumor? What is Schneiderian tumor? They're both the same?
Yes, sir, because any growth arising from the membrane, it has the tendency to grow inwards, not exophytic.
So basically, this is a transitional zone, okay, where the respiratory epithelium, the border with the olfactory epithelium, okay?
Yes, yes. Sir.
There you have this Schneiderian epithelium. Anything coming from there is Schneiderian papilloma or transitional cell papilloma, okay? Now, It is called inverted because it's not that the tumor grows. Tumor can grow inward, outward, anywhere. When you do histopathology, papilloma has papillary appearance, isn't it?
Inwards.
Finger-like projections. Those grow inwards.
Inwards.
It's on spectroscopy. Okay. Right. Any
Hello?
other diagnosis?
Sir,
Yes,
sir,
sir.
we have 4 cases. So how much time we can allot for each patient?
Yeah, 5 more minutes, sir.
Yeah, no problem. Please.
5 more
Okay.
minutes. Yes,
Sir,
yes.
next we'll have vocal cord paralysis case, sir.
Yeah.
Dr. Mahesh.
Let her go to investigation, sir. Azim, sir, let
Yeah.
her go to investigation. Yeah.
Yeah. So
Investigation.
just to complete, in this case, I would put in diagnosis of something coming from top also because we don't know whether the roof is involved on that side. What else can come from top?
Olfactory neuroblastoma,
Yes.
Right. Briefly, any other mesenchymal tumors you know of?
benign tumors like fibrous dysplasia,
No, not this. Not this. Not this.
Not fibrous dysplasia.
Please don't go into those things.
Tumor.
chondromas,
Yes, chondroma.
Chondroma, carcinoma.
Chondroma in a young individual, if it happens, even craniopharyngioma. Okay, then
Craniopharyngioma.
a non-Hodgkin's lymphoma, minor salivary gland malignancy, etc. Okay, right. So, how are you going to proceed with management?
Management. Yes.
I would like to first confirm my findings with the diagnostic nasal endoscopy, see the
Okay.
extent of the growth into the nasopharynx, then check the oral cavity, oropharyngeal
All that
examination.
you have checked, it's fine, you said.
Yes.
Yeah.
Then
What
radiolo-
other investigations? Say, Dr. Rajita, you are doing well. I can see you breathing heavily. Not required. Relax. Relax. We are only discussing. Okay.
You're doing very well. I think if Azim sir is praising you, certainly it's a compliment.
Thank you. Yeah.
then radiological investigations.
Relax. Yeah.
You're right.
Yeah, go ahead.
Like to go for contrast enhanced CT PNS.
Yes.
If there is any bony erosions or breach in the lamina papricia or the skull base erosions, then I would like to go for the MRI.
Okay. Would you do a biopsy?
Yes, sir. After confirming with the radiological investigations, then I would go for the biopsy of the.
So you do a biopsy in the operation theater, preferably, isn't it? What will you do with that biopsy sample? Will you only send it for histopath or something more?
Feel cold. Feel cool.
Immunohistological
Very good. Immunohistochemistry. So what are the
Right.
markers you look for?
Markers.
KI67, sir, which
No, that is only an addition marker. K67 is only addition marker. I would not do it here. We are looking at diagnosis.
Specific marker.
Yeah. The CD cell types,
CD cell.
cytokeratins, which can be there in squamous as well as lymphoma. If it's a child, I would look for desmin to rule out rhabdomyosarcoma. Then, where will you find synaptophysin, BCL2, neuron-specific inoles?
And sir, maybe analyze also for neuroendocrine carcinoma.
Malignant melanoma.
If it comes from the meninges, okay, then where else? Anything from nerve sheath. What is PNET?
Okay.
What is PNET? Primitive?
Neuroendocrine tumor.
Yeah. So can it be a small cell variant? So it can be a salivary malignancy. Okay. You just tell me what is secret. Where do you look for it? CD117, we look for it in adenoid cystic carcinoma. Okay. Anyway, so how will you treat this?
Yeah. Management.
After confirmation with the HP report,
It
I would
shows
like-
squamous non-keratinizing carcinoma. So how will you treat it?
and based on the extension of the tumor, if it is only localized to the lateral wall of the nasal cavity, then I would like to go for endoscopic medial maxillectomy.
Endoscopic in malignancy in squamous, I would take it with a pinch of salt. You can do. The Pittsburgh group is doing great endoscopic surgeries. So also Italians and few in India also. But I would take that with
Actually,
a pinch of salt
sir,
for malignancy.
I keep
Yeah.
telling my students,
Yes, sir.
I keep telling my students, your
Yes, sir.
experience with Pittsburgh, that they are inside out. You keep telling us that. I told
Very true.
them, so they are telling you the same thing. In Pittsburgh, you
Same.
remember, sir? You keep
Very true.
telling us.
I know.
Yeah.
See, for endoscopic removal of this tumor, you need to be an expert. Okay. I would prefer an open approach first. Considering this is an infrastructure tumor extending into suprastructure, and you saw it going till corner. So what would be your resection?
Subtotal maxillectomy.
Yeah, we don't use that term now. I would call it infrastructure maxillectomy. Okay. But if you are seeing it reaching close to the roof of maxilla, better with safer with a total maxillectomy. Okay. You tell me the
Any last
osteotomy is
question?
good take in maxillectomy.
Any last question, Anthony Francis, sir?
Sir. Yeah. Sorry, sir.
Any
We'll
last
shift to
question
next
from
case.
Francis, sir? Yeah, one last question to Rachita.
Yes.
Why maxillectomy is so successful in maxillary malignancy, provided it has not gone into the soft tissues? But very unfortunately, patient presents late to us, but maxillectomy can be one of very successful surgeries. What is the reason?
We are removing the bone itself, as such there is no conduit for the spread of the disease.
Why? How?
Conduit is there, but
You
very
modified.
tumor barrier. Okay.
Modified. You modify the answer. Sar has already told the answer in an indirect way. Because that drives into the retropharyngeal lymph glands, which usually atrophy by the age of puberty. If they go into the soft tissues, the spread will be there, the success rate will fall. Otherwise, the maxillectomy can be very successful, but patient comes to us but for the fullness of maxilla, he may not experience anything many times. And with that, I think
once it is into pterygopalatine fossa or infratemporal fossa, the outlook changes. It becomes very aggressive.
it changes. That is the specific answer. Yes. I think we can close, sir.
So thank you very much.
I think
Dr. Rajita,
Thank you, doctor.
Rajita has done very well. I am really.
Yeah.
I think
Next,
rest
we'll
of the
ask Dr.
examiners.
Mahesh is there. Mahesh, you can share. You can stop sharing. Mahesh, you can start sharing the screen.
Your screen.
Yeah. Congrats, Rajita.
Thank you, sir.
Yeah, you can stay, doctor. You can stay. You can stay here.
Next is Mahesh.
Yes,
Yeah.
sir.
Yeah.
Okay.
Hello.
Dr. Mahesh.
Mahesh, go ahead.
Good evening, sir. Good evening. Good evening, everybody. I am Dr. Mahesh from final year postgraduate from NRA
Yeah,
Medical College.
I can see that on the slide. Continue.
This is my case presentation.
Yeah, please continue.
Sir. Just a second. A 71-year-old homemaker presented to the ENT OPD with complaints of hoarseness of voice since 3 years, sir. The history of presenting illness. Patient developed complaints of hoarseness of voice since 3 years. Hoarseness was insidious in onset and progressive in nature. Complaints of hoarseness of voice is occasionally associated with complaints of coughing, liquids, and solids, sir. The voice was weak and breathy in character, with the patient facing difficulty in speech. No associated history of any diurnal variation in the hoarseness. No history of vocal abuse. No history of difficulty in breathing or noisy breathing. No history of foreign body sensation in the throat. There was no history of painful swallowing.
Cough on swallowing,
Sir?
isn't it? You said patient has cough on swallowing.
Yes, sir.
Then no history of sensation of anything in the throat can't happen, isn't it?
You mean to say there is
What is
you mean to say there is pain, but there are choking attacks. Am I right?
Okay.
Am I right?
Yes, sir. Yes,
Okay.
yes, sir. Yes, sir.
What do you understand by spillover, penetration, and aspiration? Spillover, either the cord is fixed or patient's perception of sensation is lost. There, whatever fills up in piriform fossa can overflow over the arytenoid or EI fold into the larynx. But after that, he'll perceive it and cough it out. Okay? Penetration, when it crosses the vocal cords, again, he will perceive it and cough it out, even if it's trachea. Aspiration is when it goes to the lungs. Okay? Continue.
There was no history of painful swallowing, sir. No history of any throat pain. No history of blood-tinged sputum with coughing, and no history of any weight loss or fever, sir. To go to my past history, the patient had no similar complaints in the past. No history of any fever suggestive of any viral etiology in the past.
Before you go to past, you have given a significant history of hoarseness of 3 years duration and history suggestive of aspirations.
Sir,
Isn't it?
aspiration was only occasional, sir. The patient did not predominantly complain of aspiration.
Even then, I would like you to comment on any difficulty in breathing, any exertional dyspnea.
No, sir. No difficulty in breathing and no noisy breathing, sir.
Okay. Noisy breathing is a late step. Yeah.
Yes.
We do not yet know the diagnosis. We have not diagnosed the condition. But basically, you seem to be pointing out towards larynx.
Sir.
Can a laryngeal malignancy in any phase or stage or region cause dysphagia?
Yes, sir. When supraglottic malignancy is large enough to occlude the hypopharynx, to cover up the hypopharynx and causing difficulty in swallowing, it can cause dysphagia, sir.
Azim sir would love this answer. Okay, next.
So not a known case of diabetes mellitus, bronchial asthma, pulmonary tuberculosis, and cerebrovascular attacks. But the patient had a history of left hemithyroidectomy 25 years back. We were not sure of the etiology, sir. She hasn't brought any documents.
Okay.
Personal history, the diet was mixed. Bowel and bladder movements were regular. Sleep was adequate. No loss of appetite. No drug allergies.
For completion's sake, all this is fine. But in a short case, whether he takes kebab or whether he takes vegetarian diet. Okay.
No history of any alcohol consumption and tobacco consumption.
All this should be specific in a short case. Okay.
Okay, right.
No history of any similar complaints in other members of the family, sir.
Okay.
On general examination,
in a short case, what sir is saying is that the salient features, positive features, pointing to your diagnosis ultimately alone can be mentioned.
Okay.
If it's a long case, the entire proforma has to be filled up.
Okay, sir.
That's what sir is
General examination, you can say just general examination normal. That's all.
That's all.
Okay, sir.
Nothing abnormal. Any abnormality?
Anthony sir, anything you want to add? Anthony sir, anything you want to add? Okay, go ahead.
The general examination was normal. And
Anthony sir, you get unmuted yourself.
My ENT examination, oral cavity and oropharyngeal examination.
I was thinking I'm asking questions Nobody is answering me.
No, because you got total illusion.
You didn't unmute. You didn't unmute it, sir. You thought
That's
silence was golden. Yeah. Yeah. Now you ask, sir. Yeah. Go ahead. Go ahead.
Go ahead.
Lips, gums, gingiva-buccal sulcus, gingiva-labial sulcus appear to be normal. Bilateral buccal mucosa are normal. Floor of the mouth is normal. Anterior 2/3 of the tongue is normal. Bilateral retromolar trigon.
Mahesh,
Sir.
just tell oral cavity, oropharynx normal if everything is normal.
Normal.
You
Everything
end up
is
mentioning
normal.
all these things.
If there is any
Okay.
positive lesion, you tell.
Yeah.
Sir, third palate,
what
fourth
we
palate
told
and
you.
uvula, normal and no deviation of the uvula was noted with phonation, sir. On indirect laryngoscopy, the right vocal cord appears, the base of the tongue is normal, lateral and medial epiglottal folds are normal, epiglottis appears normal. The right vocal cord was normal in its mucosa and mobility, sir. The left vocal cord was in the paramedian position. It was not showing any movements, but the left arytenoid was falling forward and it was prominent on indirect laryngoscopic examination, sir.
Okay.
There was no pooling of saliva and
What
no-
are all the
Before you go to that, Dr. Mahesh,
sir.
what
you said the vocal cord was in paramedian position and arytenoid was falling forward.
Sir.
Wasn't there any bowing of the cord?
what are the classical
There
features of vocal cord paralysis on Indian examination?
Bowing of the card.
The bowing of the cord was not significant in this case, sir.
If the arytenoid is falling forward, I would expect bowing, isn't it?
Yeah.
Sir.
What is that level of the cord compared to the opposite cord?
The level of cord was slightly lower, sir.
What was the length of the cord compared to the opposite?
Length of the cord was slightly shortened, sir.
There are classical features of the vocal cord paralysis.
Sir.
Yeah.
Okay.
Sir.
So what are all they?
Sir, there is foreshortening of the, there is the prominence of arytenoid, sir. There will be the foreshortening of the epiglottic fold, sir. The vocal cord, the vocal cord will show flickering on phonation, sir. On probe test, the vocal cord will show vibrations, sir.
There's a wavy margin, bowing of the cord, appears at lower
Bowing
level,
of the cord is also
shortening
seen
of
on-
the cord, falling forward of the arytenoid, a
Arytenoid,
short
sir.
area epiglottic fold. And how do you do probe test? Direct laryngoscopy examination, you check the probe test.
Sir.
What do you
Probe
see when
test,
you do the probe
mobility
test?
of
What's the difference?
arytenoid all that in direct laryngoscopy, not here.
Sir. Yes, sir.
Okay.
We will see if there is any cricoarytenoid fixation or not, sir. We will be palpating over the arytenoid process, and if it shows any
You
movement,
do it in clinical examination. Again, I'm asking you.
sir.
You're not supposed to do that in clinical examination. You can say,
Yes.
you can put a giraffe forceps,
Sir.
but you'll induce a laryngospasm there.
Sir.
That's done in DLscopy, not in clinical examination.
Sir.
Okay? Right.
On direct laryngoscopy, you look for that. Okay. You are
Yes, sir.
saying flicker of movement. Why is there flicker of movement? What is the reason?
Sir, flickering of the cord, because the cord is not fixed. The cord, the musculature
No,
is.
that doesn't mean it should
intact.
flicker, you know.
Sir.
Okay, let me ask
I
you, where
would
do you get
say-
fasciculations?
Fasciculation. Very
I'm
Fasciculation.
giving you a leading clue.
Sir,
Palsy.
any palsy, sir, lower motor neuron palsy, sir.
Yes, lower motor neuron palsy will have fasciculations.
Fasciculation, sir.
And after a period of time, gross wasting.
Sir.
Wasting will be there.
Sir.
And it has got early stages, it has got sympathetic supply. A
Sir.
few sympathetic fibers will come.
Sir.
Those will remain intact and then cause movement.
Sir.
Then there is interarytenoideus muscle. In between two, interarytenoideus muscle is there. One is
Yes.
gone, the other is still active. That might act and that can cause this flickering movement.
Sir.
Okay.
Yes, sir.
Right,
Yeah.
continue.
Right, go.
So this is my video laryngoscopy examination, sir.
Yeah.
Is it coming? I don't see.
It's coming now.
It's coming, sir. It is a little video stereoscopy.
Yeah, I know.
Okay. Yes, right. Why do you think that it is in paramedian position specifically you are mentioning?
Sir, the cord appears like cord doesn't appear to be abducted as such, sir. In on clinical examination, sir.
So what is your impression? If you find a paralyzed cord in paramedian position, what is your inference? If you find it in cadaveric position, what is your inference?
Sir, if we find it in paramedian position, sir, it can be an isolated recurrent laryngeal nerve palsy, sir.
Yes.
If it is in the cadaveric position or the intermediate position, it can be the total vagal palsy, sir. It can be including
both. It not be total vagal palsy. It only indicates palsy of both recurrent and
the superior laryngeal nerve.
External laryngeal nerve.
External laryngeal nerve palsy.
Vagus is a big nerve. It's go right up to the pelvis.
Sir.
Isn't it? Yeah.
It's a wanderer. Vagus is
vagabond. It means
vagabond. It keeps on moving like that. Okay.
So, suppose you have both external laryngeal and recurrent laryngeal palsy. Where would you expect a lesion?
I would expect the lesion at the high vagal level, sir. Somewhere in the high vagal lesion, would expect.
Where is the inferior ganglion?
Sir?
Where is the superior ganglion and where is the inferior ganglion of vagus? And I would go a bit further, where is the nucleus?
So nucleus ambiguous and the dorsal nucleus are located in the middle.
Nucleus ambiguous and there's something else.
Dorsal
it's not solitary.
Nucleus tractus solitarius.
Okay. Sir. Okay. Where is the superior ganglion? Where is the inferior ganglion?
Sir, after exiting the jugular foramen, sir, we get the superior and inferior.
Superior ganglion is just above the jugular foramen.
Sir.
It is above that. Sir is giving you a clue.
Sir.
Okay. So phylogenetically, in evolution, which is the last muscle to develop in a living being?
Sir,
a human being for that matter.
With respect to the larynx, it is posterior cricoarytenoid, sir. It is
excellent. Go ahead. Next. Go ahead. Yes, you're right. Go ahead.
Sir, after the posterior cricoarytenoid is the only abductor, sir. Like abductors
I agreed. Next. You know the concept. Very nice. Good. Next. Yeah. I think Francis sir will ask him how you manage this case. Which thyroplasty you want to do? You want to do thyroplasty in this case? If you so, which thyroplasty and how?
Sir, this case presented actually after with a history of 3 years of hoarseness of voice, sir. Normally, I would have waited for 6 months to 12 months, but this patient came with a persistent hoarseness that has lasted for around 3 years. So I would want to go for a thyroplasty.
Do you do any investigation for the patient?
Yes, sir. I would actually want to rule out any causes that lead to the vocal cord palsy, sir.
Any effects of this vocal cord palsy? For that, do you do any investigation?
Sir, CECT of skull base to diaphragm, sir. Contrast enhanced CT to rule out all the compressive and obstructive lesions, even malignant lesions along the course of the recurrent laryngeal nerve.
Okay.
Before I can go, I will also do a chest X-ray, sir, like to rule out any.
Scan, man.
Yes, sir. Yes, sir.
Yes. No, any test would you have guts to do?
Sir, stroboscope.
You can tell, man.
Would you like to see? Would you like to estimate the outcome of your surgery?
Gutsman
with some
test.
guts.
What is Gutsman test?
Sir, on giving pressure on the thyroid cartilage, the voice there is improvement in voice, and these are the patients that will benefit from thyroplasty, sir.
Right. Guts is closing, Cartil is lateralizing and creating space. That is the difference between the two. So how do you do
You
that?
said this patient had history of hemithyroidectomy.
Yes, sir. The
What about-
patient had history of
could you-
thyroidectomy 25 years back, sir.
No, agreed. First, listen to the question. Did you palpate the neck? Is there any palpable mass? Is there any
Mass.
palpable mass on the operated side?
Yes.
No, sir. No palpable mass on the operated side.
Why sir is asking that question?
You could feel the cartilages?
Maybe any recurrence or remnant thyroid.
More
that
than
can-
recurrence. More than recurrence.
More than recurrence.
A pre-existing nodular thyroid going in for malignant change.
Malignancy. It could have gone into
Okay.
malignancy, infiltrated the nerve, and that's how you got the paralysis, maybe. But of course, 3 years duration is one thing, but papillary carcinoma has a long duration.
And not only that, see, even post-thyroiditis, you have a small fraction which do go in for malignancy, either follicular or sometimes even lymphoma.
Sir.
That's why I asked you.
Sir.
Okay? Right.
Of course, recent concepts of American Thyroid Society and European Thyroid Society is that even if there is malignancy, they are just enucleating or removing that mass and retaining the regular
Yeah.
thyroid tissue. That's a
See,
little
the
controversial.
rationale is no, sir. The rationale is very clear. Suppose you have a patient less than 50 years of age and a nodule, solitary nodule, which is malignant, less than 4 centimeters, without any extrathyroidal spread or without any lymph node metastasis, you can do a lobectomy or a hemithyroidectomy. But you are safer in a follicular neoplasm with a total thyroidectomy. But even there, this lobectomy holds good. Okay? You cannot do that for medullary carcinoma. You cannot do for poorly differentiated variants or aggressive
Yes,
variants of.
or anaplastic variants. And even follicular transformation can be aggressive, sir.
Yes.
Papillary, it is good, but okay.
That's why with follicular, problem is it metastasis through blood.
Yeah.
So bone and lung metastasis happen early in follicular. That's why we are a little more aggressive with it.
Francis, sir, would you like to ask him about the window he would like to make and celastic block?
No. Oh, what surgery you want to do for the
Sir, I would like to do type 1 Ishika's type 1 thyroplasty, which is also the medialization thyroplasty, sir.
only that?
Or I can also do injection laryngoplasty, sir.
No. Thyroplasty, only thyroplasty you'll do or something else you do along?
Arytenoid adduction, sir.
Why are you tired?
Arytenoid adduction with type 1 thyroplasty
Why arytenoid adduction?
to address the posterior glottic gap, sir.
How do you know there's a post-glottic gap?
On video laryngoscopy, sir. After on video laryngoscopy,
What will happen if there is a posterior glottic gap?
because enough pressure will not be.
No, wait. What will happen when there's a posterior glottic gap?
When there is a posterior glottic gap, the patient will have suboptimal improvement in voice, sir. Because there will be leak of air.
Which part of the larynx contributes for phonation? Which part of the larynx is contributing for the prevention of aspiration?
Aspiration.
Sir. Posterior glottic gap will see that there is aspiration, and anteriorly it is phonatory.
If there's an aspiration for long duration, what happened to the lung?
Sir, okay, I didn't get the question, sir. I'm
If
sorry.
the patient is aspirating for a long time, what are the changes seen in the lung?
Aspiration pneumonitis, sir.
Chronic aspiration pneumonitis.
Sir.
How do you diagnose?
Sir, on chest X-ray, consolidation can be seen, sir.
So on a CT
The consolidation is an acute event. When
Sir.
it's chronic aspirations, you will not find consolidation there,
Sir.
especially if it's silent aspiration.
Sir.
So if there's a silent aspiration, you look for basal changes, and if that is the case, you got to check the pulmonary function test.
Sir.
If there's a problem with these two, you got to necessarily do a arytenoid adduction.
Sir.
Okay, otherwise you can go away with the doing only the addressing the anterior two-third of the vocal cord.
Okay?
Okay.
Auscultate first, then confirm through radiology. STEP is the best instrument.
Sir.
And will you do routinely video laryngoscopy for any thyroid surgery? If so, what is the scientific reason?
Sir,
The patient does not have any voice change. He has come. You have to do a thyroidectomy, hemithyroidectomy.
sir,
Would you like to do a video laryngoscopy? If so, why?
Sir, I would like to see for the intactness of the recurrent laryngeal nerve and see if there is any pre-existing vocal cord palsy, sir. Because it is important.
He doesn't have voice change.
Sir.
He doesn't have any change in voice.
What is pilot study?
It can be due to compensation, sir, but there can be
Bailey and Love mentions
Sir.
a hopping 3% of normal population having a silent vocal cord palsy, compensated, and legal issues.
Any slowly developing
Pilot
palsy,
study.
any
That is
slowly
called
developing palsy will give adequate time for compensation. So he will not complain to you about voice change. It's
Voice
for you to
change.
detect.
Detect. Okay, sir, are we done?
Done, sir. We'll go for the,
Yes.
sir.
Next case.
Just one question.
Next year
Last
case.
question. Azim sir is asking last question.
Suppose the external laryngeal alone is paralyzed,
Sir.
what will happen? And what's the nickname of this nerve?
Sir, external laryngeal nerve, if it is alone paralyzed, there will be paralysis of the cricothyroid muscle, sir. Because of this, there will be unopposed action of the thyroarytenoid muscle, which will cause shortening and bowing of the vocal cord and prominent arytenoids.
What will happen to voice?
Voice.
Voice will be weak, and because there will be no tension, sir. No tension.
Phonosthenia, yeah, there will be no tension. So
He will be having phonosthenia, sir.
patient cannot use a high pitch at all.
Raise the
Okay.
voice more for that. Yes.
What's the nickname of that nerve? Nerve of Galli-Curci. She was an opera singer who lost it, and she lost her job, though she didn't have any hoarseness, because she could not build a high pitch in opera singing.
Yes.
Okay.
Nerve
So
of
it will-
Galli-Curci and McGregor calls cricothyroides muscle as the tuning fork of larynx.
Yeah. Okay.
That pitch. Okay. Right. Very nice.
So Joel's triangle, Bear's triangle, all that should be at your fingertips. Okay.
Okay.
Good.
Thank you, sir.
Joel's above, Bear's below. Okay. Congrats, Mahesh.
Thank you, sir.
Very nice. JP, next is.
The next year case by Koti.
Yeah, Meghna.
Hello?
Yeah.
ఏం లేదు బాగున్నాడా ఇప్పుడు
I think people who are enjoying this program most are three of us, sir. Azim sir, Francis sir, and myself.
Yeah. It's always a learning process, sir.
Learning
I think
process.
that's what,
Meghna,
Learning process. Meghna.
Yes, sir. Yes, sir.
Meghna, you are
start sharing
ready?
your screen, doctor.
Share your screen.
I can share after. Stop sharing.
Mahesh, you stop sharing now.
Mahesh, stop sharing.
Stop sharing, Mahesh.
Sorry.
Yeah. Meghna, you can start sharing.
Hello?
1 second,
Meghna.
sir. Yes, sir. I am trying, sir. 1 second.
Okay.
ఇంకా నాకు మహేష్ దే కనపడుతుంది వస్తలే
No, first you open your presentation. Keep your presentation open first. Then you go for sharing.
Yes,
Open
sir.
it first.
You minimize
Yes,
your,
sir.
yeah.
Yeah. Meg, come.
Good evening, sir. I am Dr. Meghna and I have a ear case presentation today.
Yeah.
Good evening.
Go for slideshow. Otherwise, also no problem. Yeah.
23-year-old female, Monica, resident of
Hey, one thing I'll suggest to all of you, stop this male, female and all that 23-year-old girl or 23-year young lady. Okay? Right.
Abroad, the convention is lady and gentleman, sir. No longer
Yeah.
it is male and female.
Very true.
Yeah.
Very true.
Madam, your presentation should be, don't include too much of negative history. Just
Yeah.
concentrate on positive history, relevant
Positive findings. Relevant
then
positive findings are
positive
enough.
findings and then diagnosis. Okay?
Yes.
The short case. Yeah. If you give more time for discussion than your presentation. Yeah.
Okay. Who is a daily wage laborer by occupation, came to OPD with chief complaint of left ear discharge for 3 months duration. Patient was apparently well 3 months ago. Then she has left-sided ear discharge, which was insidious in onset, gradually progressive, mucopurulent in nature, yellowish color, intermittent, copious, non-foul smelling, non-blood tinged discharge, which is aggravating with URA and entry of water into the ear and relieved temporarily with medication. Rest all history. And she had similar complaints in the past in left ear 1 year ago, for which
1 minute. Will an intermittent discharge will be progressive?
initially the episodes were lesser. Later, then she had
It's
more.
contradiction. The diseases can be a continuous disease or continuous disease can be static or progressive. Intermittent disease will come on and off. All the infective diseases are chronic infective diseases are mostly intermittent. It's not a malignant disease where you will go and tell your complaint that it's in nature. Naturally to us, because we keep presenting a lot of benign and malignant tumors. Okay?
Yes, sir.
Okay, right.
She had history of similar complaints in the left ear 1 year ago. She has no other significant past history, no significant family history or personal history. And general examination is normal. Systemic examination is normal. Coming to ENT examination, ear examination with bullseye lamp under proper illumination. All the pinna.
You have nicely written pre-auricular, post-auricular. Why did that pinna come? It's a layman's term. Why not auricle? Okay.
Okay.
Right.
No tenderness over the tragus pinna or 3-point tenderness is negative.
There cannot be normal tenderness. Okay. Tragus tenderness absent.
Absent.
There's no normal.
Say tenderness is absent. It is not, or better wording is, it's not tender.
Yes, sir.
Okay.
External artery meatus and external artery canal are normal. Examination of tympanic.
How long patient had a ear discharge? 3 months.
3 months duration, sir.
When it is last discharge?
2 weeks ago also she had one episode of discharge.
Till now patient has got a discharge. Don't you see discharge in the external canal?
So she is using medication since 2 weeks, sir, and after that it has subsided, sir, temporarily. She's
okay.
Right now ear is dry.
yes, sir.
Yeah.
Not discharging profusely as such.
Okay. Suppose you are planning for surgery.
Yes, sir.
What is the importance of this external artery canal? What is the importance of examining this external artery canal?
We have to see if we should examine if the external artery canal width is normal or if it is stenosed. And we should examine if the skin over the external artery canal is normal or not. Any diseases of the skin of the external artery canal can impede flap uptake and healing.
Which conditions can you name?
Psoriasis of the skin of external artery canal, eczematous conditions, seborrheic dermatitis, or acute otitis externa.
Okay.
Acute, will the patient let you examine?
No, sir.
Okay. Yeah.
Pars flaccida appears normal on the right side. On the right side, pars tensa is intact and cone of light is present. On segalization, the right tympanic membrane is mobile. On the left side, pars flaccida is normal. Pars tensa, single moderate-sized central perforation in the inferior quadrant, occupying the anterior and posterior inferior quadrants of pars tensa. Margins of perforation are regular. Tympanosclerotic patch is visualized in the antero-superior quadrant. Rest of the pars tensa appears mildly inflamed. Structures seen through the perforation are middle ear mucosa, which is edematous and congested. Hypotympanic air cells are normal. On segalization, remnant tympanic membrane is not mobile. On
How will
otoendoscopy,
the tympanic membrane mobile when the perforation?
not mobile on perforation. There is
That's okay. Show the photograph. What are all the
Okay.
structures seen through that?
you
You
can
said
see
middle layer mucosa. What's that bulge? Threat.
it is the promontory from
What
You
is
have to
base?
say it. What else is in?
hypotympanic air cells. We can see
Array, before hypotympanic
niche.
cells.
round
Some-
window, round window niche.
Said at first.
Yes.
Hypotympanic air cells, it requires a lot of struggle to see.
Okay. Unique folk test.
I think she must have seen too many central perforations. She must be identified hypotympanic air cells. Okay. On the other side also, let us say the tympanic membrane is retracted. It is possible, tubotympanic. A mucosal disease is taken tube and tympanic cavity. Suppose it is just retracted on the opposite side. How do you say it is retracted? What are the features of the tympanic membrane by which you can say it is retracted?
We can see a distorted cone of light, dull lusterless tympanic membrane, prominent anterior posterior malleolar folds, medialized
Mallear folds. Malleolus is like, yeah.
malleolar fold,
Foreshortening.
from-
Foreshortening.
foreshortened handle of malleus, and prominent lateral process.
Okay.
Right.
On
Go ahead.
segalization, there's a restricted mobility of the tympanic membrane.
Tympanic membrane.
Yes,
On segalization.
yes, sir.
Okay.
Tuning folk test on the left ear.
Yeah, we saw your tuning fork test. It only shows Rene negative for 256 hertz in the left ear.
Yes, sir.
So what could be the expected conductive hearing loss?
Mild conductive hearing loss, sir.
No,
Did-
mild, moderate, severe, profound will come later. What is the range in decibels?
20 to 30 decibels hearing loss, sir.
15 to 20.
Like
Only
256, 51, 1024. Certain amplitudes are given in the book. No, how much it is lost?
256 is 20 to 30. Or
I'm
512 is
telling you
30.
15 to 20. Okay.
20.
20 to 30 is when even 512 is negative. Okay.
30 to 45 is 1020.
No 30 to 40. About 30, everything will be negative. Okay.
Okay.
Weber's test is lateralized to the left ear. Schwabach
How much difference in threshold is required for Weber to lateralize?
at least
Between
7
the
decibels threshold difference is required.
5. You can say 5.
5 decibels. 5 decibels.
Right.
That is more sensitive test of
Yeah.
the Weber's test. Yes.
Suppose patient is malingering of having hearing loss in one ear. Can you modify your Weber test to catch him?
We can do Chiamani-Moose test.
Chimani-Moose test. Very good. Okay,
Very
continue.
good. Very good.
Vestibular test, vestibular test is absent in both ears. All the vestibular tests are normal, sir. Facial nerve is normal and symmetrical on both sides. Nose on anterior rhinoscopy, septum is
Symmetrical or
They're
not,
all
we don't know.
normal.
This is symmetrical. Okay.
symmetrical.
Yeah.
Symmetrical.
Nose on rhinoscopy, septum is midline, oral cavity and oropharynx appear normal. Neck appears normal, sir. My provisional diagnosis is left chronic otitis media, mucosal type, active disease with mild conductive hearing loss without any complications.
Very good. How will you manage?
How a tubotympanic disease can give rise to complications. It is supposed to be relatively safe disease. How this relatively safe disease can turn unsafe?
Tubotympanic disease can have convert into a squamous type of disease due to migration of epithelium through the edges of the perforation, and it can turn into a squamous type of disease.
Any metaplasia can happen?
Any metaplasia can take place.
Squamous
Basal cell.
metaplasia of the medullary mucosa also can lead to.
Okay. Can you convert into unsafe one?
Sir?
Any destruction. It has an edge, you know.
Yes,
Annulus it has. Yes.
Yes, erosion of the bony annulus can also cause migration of the epithelium into the middle ear.
And granulations form.
Can you cause this safe disease into unsafe during part of your treatment?
Yes, sir. While doing a tympanoplasty, we can, if any remnant epithelium is left inside the middle ear before repositioning the flap, it can lead to formation of epithelial pearl.
Yeah.
Epithelial pearls. Okay.
That can happen in onlay method, isn't it?
Yes, sir.
Underlay is always safer.
Yes.
Underlay is preferred. What are the complications of underlay?
There can be medialization of the graft, reduced middle ear space.
Yes.
If anterior tucking is not done properly, then there can be residual anterior quadrant perforations.
Anything? I'm asking you bluntly.
Blunting of.
That happens with onlay. That happens with onlay.
Overlay.
Onlay or underlay?
Blunting is more common with onlay techniques.
Not more common. Happens only in onlay. Okay. How can it happen in underlay?
Okay. What are the graft materials you want to use?
The most commonly used is temporalis fascia graft, sir.
Why?
Other than that, temporalis fascia graft, it can be harvested in the same incision. It has a similar thickness as that of the normal tympanic membrane, and it has a low basal metabolic rate, so there is low.
That should come first. Okay. After the same incision, that should come first. Okay. Low BMR.
Increased risk. There is increased chance of uptake, and it has good vibrational properties for better hearing outcomes for the patient.
Set of the graft. What happens when you put a graft there?
Epithelialization of the graft happens, sir. It will take. Epithelium will regrow from the freshened margins onto the graft, and
so that's like a scaffold.
It is only a scaffold. It has to be followed by epithelialization later, but that heals the perforation. But as such, for a perforation, it doesn't heal like other tissues in the body by fibrosis.
Yes.
You will get an epithelial card along the edge, which you have to freshen. Why that happens in tympanic membrane?
No, there is absence of wound healing factors like transforming growth factor beta, hyaluronidase, interferon alphas. So there will not be healing, sir. Edges are epithelialized, so there will the central perforation fails to close by itself.
Is it the presence of transforming growth factor beta 2 or absence that causes epithelialization? Okay, all right. You got the point. We have to freshen the edges. That's the reason. Okay, all right.
Once you have epithelialized edge, it will stop growing.
Yes, sir.
It's like having fine enough.
Stop closing. What are the non-surgical methods of treating a central perforation?
We can freshen the with
yes, okay.
acid and with
that's a very good guess. Yes. Which material you want to use?
Cigarette paper can be used as a.
Okay. Why cigarette paper only? Your gel foam inner cover sterile piece you can use.
That also you can use.
So, cigarette paper, you can't use it to close the perforation.
It is only used as a scaffold so that the freshened epithelium margins of the epithelium will grow.
Why? Cigarette paper is a foreign body. That will cause infection. The cigarette paper test is used to see that your audiological gain
Gain
following.
will be there. What do you call that test?
It's
What
only
do you
the
call that test?
Patch test. Patch.
Okay. Suppose articular damage is there inside.
So this conservative management is better for small perforations. With a large perforation, what will happen is they'll develop a dimeric scar,
Yes.
dimeric membrane. Okay. Right.
I think. Are we done, sir?
How
Continue,
would
sir.
you,
Francis, sir, and Azim, sir. Please continue.
yeah, how would you know whether there's any ossicular damage here? Of course, your tuning for test suggested there's no damage.
Yes, sir.
What else?
Radiologically, we can do a CT temporal bone to check the ossicular status.
Your patient is poor. Your patient is poor. Your patient is poor. Something in your clinic you can do.
As we are able to see the round window niche, we can check for ossicular mobility by hand normally.
You mean you are going to do round window test, light reflex?
No. Sir is asking. Preoperatively,
Operating
how do you
microscope,
know
you can see the ossicles, isn't it?
ossicular damage?
I'm
Auto
able to
microscope is your first answer.
What are the methods by which you know there is ossicular discontinuity or damage preoperatively so that you can plan osteoplasty during surgery?
by audiometric methods, pure tone audiometry, and by radiological CT scan, and on
Forget your radiology now. Okay. Simple auto microscopy. Why I asked you this? Because there is a tympanosclerotic patch.
Yes.
How sure you are it's not there in interossicular ligaments? Okay. Right. So now that there is no ossicular damage, you will only do a maryngoplasty. What's the difference between maryngoplasty and type 1 tympanoplasty?
Yes.
In myringoplasty, we are only repairing the tympanic membrane without checking for the ossicular status. In tympanoplasty,
So you will keep your eyes closed and put a graft. Okay, you're right. Evaluation of the middle ear. Okay, and
Yes, you are right.
disease or post-disease process. Right.
Sir is asking that question from Shambo. Tympanoplasty means extinguishing the disease from middle ear and restoration of hearing to as close to normalcy as possible without grafting tympanic membrane. That's why he asked that question. You should tell that. Then he will give two, 3 more marks more.
Now, during the complications or rather sequelae of underlay, you said reduce middle ear space. I would like to know in which tympanoplasty, Wolstein-Zollner method, you would create a cavum minor, and what is that cavum minor?
Cavum minor.
cavum minor is created in type 4 tympanoplasty, sir.
Very good. So what will be the defect there?
We are placing the tympanic membrane graft over the oval round window.
Yeah, why?
So that to create a phase difference between the stapes footplate
Very
and the
good.
top window.
So this happens when you have a big perforation with ossicular damage where the sound waves are entering both through oval and round window, causing baffle effect. You are
Yes.
preventing that by creating a
baffle effect.
Okay.
Round window
It's
baffle.
rather outdated now because we are doing ossiculoplasties. Earlier they used to do it very frequently.
What
So
is
a big
type
cave like
6?
here, you are creating a small cave by covering the round window. Okay. What
Type
is
6?
type 6?
Type 6 is sono inversion, sir. Where the
Yeah.
graft is placed only over the footplate of the stapes, exposing the round window to the external environment.
It is
So
the
you are
reverse.
reversing the sound.
Reversing the
Okay.
procedure. What is
That
type
doesn't
5?
come- That doesn't come in Wolstein-Zollner. That was done by Garcia. Okay.
Garcia, actually.
Type 5 fenestration surgery is done, sir.
Why we
Creating
don't do it? Why we don't do it?
in a fixed stapes footplate, we can do a fenestration surgery.
Suppose you are expecting problem, you see a otosclerotic focus or arthritis of the foot plate or granuloma near the foot plate, they used to do type 5. Now we have stopped it. Why?
We are doing stepidotomy.
No, agreed. Why have we stopped type 5?
It will cause increased risk of infection to the inner ear through the fenestration.
I'm very sterile. My OT nerve is very, very sterile.
Where will you put the fenestration?
Or the lateral semicircular canal, sir.
So what is the high chances of what?
Nystagmus, risk of complications like
What is
nystagmus.
Tullio phenomenon?
Tullio phenomenon.
Hearing of loud sounds will cause
Convection currents. The sound waves will go through that fenestra, cause convection currents, causing giddiness. Okay. Yeah. And what is air caloric test?
by installing water into the middle ear, which is
Oh
hot.
my God, air caloric.
Air caloric, air current, hotter, warm or cool air currents into
Usually
the.
we use Pentas Grant apparatus, but here why I asked you is because nothing will happen in South India. Even in South India, suppose he goes to Ooty, a gush of cold air can behave like a cold caloric test for him if you do fenestration
Yes,
operation.
yes, sir. Yes, sir. That's a very relevant. One last question. Semicircular canals are concerned with balance or hearing?
Predominantly with balance.
Not predominantly balance. Why are you making a fenestra in organ of balance when you are trying to restore hearing?
Sound waves when are passing through are dissipated to the semicircular canals also.
Oh, no. They don't just go anywhere and everywhere. Now you'll pull me into physiology of hearing.
If you remember that vestibule diagram.
Even within the cochlea, the low frequency waves, which part of cochlea responds to them and which part to high frequency wave?
Basal high frequency, base low frequency.
Basal for low frequency. Okay.
Okay, sir.
Are we done, sir? Are we done, sir?
Yes, sir.
One last question. What is the action of stapedius? What does it prevent?
When ear is exposed to loud sounds, stapedius muscle contracts and pulls the stapes laterally to protect the ear from loud sounds.
No, not loud sound. From the sustained damage of low frequency sound, they travel to the apex. High frequency hits the basal turn. Okay. It's to prevent damage by the sustained damage of low frequency sounds.
Sir is using a very relevant word from Scott Brown. It is not acute damage that stapedius prevents.
Yeah.
It is sustained damage for a long time. For adaptation, that stapedius works. For sudden blast by the side, it doesn't work. That's
Diwali is coming, so go back and read up what is temporary threshold shift and what is acoustic trauma. Okay. Good.
Okay, sir.
Yeah. Okay, sir. We'll go for the next case presentation.
Yeah. Excellent, Megan. Go.
Thank you.
Yeah, you can stay with us. That's no problem. Yeah, next.
Okay.
You can stop the screen sharing. Then the next one. Yes, ma. Chandana.
Good evening, sir.
Yeah.
Good evening.
My name is Shamna from SVMC, sir, final year PGC.
Good.
You share the screen.
Please share the screen.
Sir, share, sir.
Okay.
Sir, can I start, sir?
Yeah, sure.
So, presenting the case of a 6-year-old child, Gopi Krishna, coming from Kalahasti. Informant is the child as well as the mother.
Okay.
The chief complaint is presenting of left-sided nasal obstruction since 6 months. History of presenting illness. Apparently normal child presented with a left-sided nasal obstruction since 6 months, which was to the present state. It was
Amma, you
aggravated during the episodes of cold.
Amma, you mentioned the positive findings. I mean, positive salient features in history pointing to diagnosis. Okay, negative things you can avoid because this is
Yes,
short.
sir.
That's what
See,
all the SARS
I'm sorry
were telling.
I'm sorry to interrupt. Many times, for paucity of time, to have more time for discussion,
Yes,
in
sir.
short case, we just ask you the diagnosis and ask you to justify it.
That's all.
Okay.
Many times, short case in the PG examination will be only findings and diagnosis. Okay, but we wanted to, like JP and Kumar wanted, we wanted to cover a little comprehensively.
Yeah.
That's why we are allowing you to do this. You can go ahead. But tell positive. Okay? Yeah, go ahead.
It aggravates while lying down, and there is also associated left-sided nasal discharge, mucoid inconsistency, not foul swelling and non-blood stained. There is also associated history of change in voice, associated history of snoring and mouth breathing, and also there is history of loss of smell.
No, you said change in voice. What sort of change? You took the history.
Yes,
You
sir.
said it was given by mother and the patient.
Yes.
So what did you notice in the voice?
The mother explained it as.
So forget the mother. I'm worried about the child. What did you notice in the voice?
Mother told that there was a
No.
change in
Doctor,
the
try
voice.
to understand the question.
The dullness of
Doctor.
the voice was explained.
Dr.
Like
Try
Shaman,
to understand
Amma,
what
Forget what the
kind
mother
of
told.
change in voice.
You heard
That
the
is
patient.
asking you.
Yes, sir. Yes, sir.
What kind of change in voice?
Mother told that that
Forget
is
the mother. What did you hear, madam?
okay. Voice change, sir. There was a hypernasal tone of voice, sir.
Yeah.
That's all I wanted. Rhinolalia clausa.
Yes, why not?
Okay, continue.
There's no history of sneezing, running nose, or itching or running nose. There is no history of any nasal bleeding, no history of any headache, facial pain, trismus, no history of any earache and ear discharge. Past history, no history of similar complaints in the past, no history of asthma or
Past history not
tuberculosis.
contributory. Proceed.
no.
Go to your
Positive
examination.
findings. Negative you avoid. Let
Yes,
us
sir.
save time for
Go
discussion.
to your
Yeah, next.
examination, doctor.
Sleep is disturbed, sir. In persons with a
Examination.
disturbed sleep, sir.
Sleep, yes, okay, agreed.
Yes, system examination normal, sir. External examination nose normal, sir. Tip raising also normal. On anterior rhinoscopy, sir. Examination there is DNS towards right side floor over the left nasal cavity. There is a discharge.
Yeah, PG
On the
level.
examination.
Dr. Shaman, you seem to be super fast. In PG level, when you said DNS, you have to describe the DNS. Just saying DNS to write is not adequate.
Okay, sir.
Please
There was
describe
a-
the DNS.
Yes, sir. There was a deviation of the nasal septum towards the right side, sir. Like no. And on examination of the left nasal cavity, sir, over the floor, discharge was noted, sir. And in the left
No.
nasal cavity,
Amma, in
Yes.
deviated nasal septum, would you like to describe anything more? Any sharp?
Is it anterior,
Is it
posterior,
high
cartilaginous,
anterior,
bony, any spur,
posterior,
any dislocation?
C-shape, S-shape, high, low? Anything you want to say about it?
it's
That's what
it's
sir
a-
asked you.
Yes, sir. It's a C-shaped deviation of the right nasal septum, sir, with congested nasal mucosa. No spur or no inferior turbinate
Is it anterior or posterior?
Anterior deviation, sir.
How did what?
Cartilage is part of the septum, sir.
Anterior to what?
Anterior, sir.
Anterior to what? Which line?
Anterior part of the septum.
Anterior to which line, madam?
Which?
What is line? Which line divides septum into anterior and posterior?
Cortis line, sir.
So you should mention that.
Yes, sir. Anterior to the
Okay.
cortis line.
What is
Any spur?
Line which passes from the nasal process of the frontal bone from the nasal process to the maxillary process, sir. And it divides the septum into anterior and posterior, sir.
What is Bladina classification?
What is that?
What is Bladina classification?
Bladina classification.
Yes, for septum.
Ladiner classification.
How do you classify? What is
Septum classification.
Find out all these things, okay? Mladina classification, MLA, DINA, Mladina classification, what is terminoseptal deviation? Okay, right, proceed.
Yes, sir.
This is not your...
On examination of the left nasal cavity. On the examination of the left nasal cavity, sir, inferior hypertrophy noted, sir, and there's also presence of discharge. And on inspection, there was a pale, smooth, glistening grayish white mass filling the nasal cavity noted between the septum and the inferior turbinate. On probing, the mass was insensitive to touch, soft in consistency, does not bleed on touch, and can be propped all around except the laterally. It is mobile as well as compressible.
Okay, continue.
Posterior rhinoscopy was not done, sir, since the
In a
mass is
6-year-old
visible
child,
through
you
the
did posterior
oropharynx.
rhinoscopy? Even I will find it difficult
No,
to
sir.
do.
No, sir. It's not done, sir. The mass is clearly visible. Not done. We can't.
Then why do you mention it?
No, not done.
Okay.
The mass is
Examination of oral cavity in the oropharynx. You are seeing the mass hanging into the oropharynx.
Oropharynx.
That's what you saw. That's
Yes,
what you are
sir.
telling as posterior rhinoscopy.
Yes, sir.
Okay.
No, wait. When the mass is in the nasopharynx, an obstruction, the nasopharynx is bilateral, never unilateral.
Yes.
Then how do you say left-sided nasal obstruction?
Complaint was only left-sided nasal obstruction, sir. Was asked.
It cannot be.
Yes, sir.
When there is a nasopharyngeal mass,
Yes,
how
sir.
can when it is as long as it's the nasal cavity, it's fine. If it goes to a nasopharynx, particularly when the patient expires, it will come like a ball valve and upset both choana.
Okay.
Will it upset only one choana?
No, sir. It will obstruct both the choana, sir.
Yeah.
So partial, opposite
One-
side also partial obstruction.
When the patient is not telling properly, or you don't know how to take a history properly, or you are not Harichandra, and you are not Harichandra, you should, if you know the fact, you should have put it.
Yes, sir.
Okay.
Explain. Yes, sir.
Right. Proceed.
Dr. Shaman,
Why?
for you can say the patient has
sir.
developed a habit of sleeping to one side and
Why is the
breathing through mouth. Patient has developed a habit of sleeping to one side and breathing through the mouth.
Yes.
You could have said that to guard yourself. Okay.
Okay. It's a nasal polyp coming. Ultimately, you are going to tell it as antral polyp. Yes.
Yes, sir.
Yeah. Why that big mass is growing back
As
into the nasopharynx?
as a PG, I would expect you to say antroconal, but I'm more interested in differential diagnosis. More so
Yeah.
because it's a child.
Yes.
Because it is hanging into the nasopharynx, from the nasopharynx into the oropharynx. Why such big mass coming from the nasal cavity? It should be hanging through anterior nares. Why is it hanging backwards?
Because, sir, the passage is like it arising from it can arise from the accessory organ through the posterior fontanelle and it passes posteriorly, sir. And another thing is that the mucociliary clearance is also towards nasopharynx and the nasal cavity edge is also sloping, sir, which makes it the mass to pass through the choana posteriorly to the nasopharynx.
Inspiratory current is more powerful than the
And respiratory current.
Then
Inspiratory
more
current.
more roominess posteriorly than the anterior. He pulls it posteriorly. All the factors.
And another aspect is many times the uncinate process. If it is
blocks
prominent,
anterior growth.
it acts as a shelf anteriorly so that the polyp cannot pass across the space available, crossing the uncinate process. That is another reason. Okay. Those are all the reasons. Right. Okay.
So what is
go.
your differential diagnosis?
Differential diagnosis.
Sir, differential because the child age is 6 years, sir. I consider it can be an antrochoanal polyp, sir, or it can be also a congenital tumor such as like encapsulocele or a meningocele. It can be, sir.
Is it a tumor?
Then don't call it tumor.
Tumor. Sir.
I agree.
Congenital mass.
Meningocele or meningoencephalocele. Don't call it tumor then. Okay.
Yes.
Then what else?
It can be A glioma, sir. It can be also a glioma also present in the
Glioma.
same.
Okay.
Can be.
Glioma, not that innocent, madam.
Then it could be
Any common structure in the nose, routine anatomical structure.
deviated nasal septum, inferior turbinate hypertrophy, sir.
Simple nasal polyp.
It may not be coming from antrum at all.
Yes. Okay.
Right. So how will you manage this case?
We will.
No, you have not done a post-nasal examination. It's very difficult to do a diagnostic endoscopy. Do you do any imaging?
Yes, sir. X-ray is done, sir. X-ray nasopharynx lateral view also is done, and CT or paranasal sinus is also done.
How will you differentiate adenoid from the endogonal polyp?
Sir, in an X-ray nasopharynx lateral view, if there is an air shadow between the mass and the posterior pharyngeal wall, you can see an air shadow, then it will be an anthropoidal polyp. Dot sign or present sign.
Dr. Shaman, you seem to be in top gear always. Listen to what the examiner is asking. Air will not cause a shadow. Air causes lucency. Okay? Radiolucency. Okay.
Semilunar lucency, semilunar shadow will be present. That is dot sign. Otherwise, there will not be that gap. That's what he's asking.
What are the parts of endogonal polyp?
His cyst can come in the nasopharynx. Any cysts or any young age tumors or any cysts?
Front of the nose. Front of the nose.
Front of the nose. Dermoid cyst.
Naso something cyst.
Nasolabial cyst.
Anything from the
palate?
nasopharynx
can happen there.
I'm proving a thorn in your flesh. I'm proving a thorn in your flesh.
Make you dance a waltz.
Nasopharynx.
There is a wall behind you, and I'm a thorn in your
There's
flesh.
a thorn and a wall.
Thorn wall cyst, have you heard? And sir, Azim sir told about craniopharyngioma. It comes from which pouch?
Thorn wall cyst arising from the
Comes from which pouch?
You like Tom or Jerry? You like Tom or Jerry in that serial? Tom. And then your answer is wrong. If you had said Jerry a rat, I would have accepted.
Okay.
Rat case pouch.
Rat case pouch. Right. Any other differential diagnosis? Tell sir. Young child, 6 years.
So I am suspecting a meningocele, large meningocele. How to rule out clinically?
Clinically, sir, the mass will be intranasally. When we see the mass, will be pale mass only. But when we are probing,
it not be. It depends on how big the defect is.
Defect,
how will you rule a
the size of the mass will increase while coughing or any straining activities, sir.
Coughing or crying.
Coughing or crying.
Right. Now, presuming this is antroconal polyp, how will you treat?
So, surgery is the treatment of choice, sir. We advise them for endoscopic sinus surgery, sir. And since it's a child, we will consider a simple polypectomy. Along with that, we have to clear out the.
Why simple polypectomy?
No, not just polypectomy. Polypectomy. Along with that, we have to consider for medial maxillary androstomy too, to remove the tumor.
Probably seeing the size of the mass, the ostium would have been enlarged. Anyway, if you give a wider ostium, better. Okay, then.
You wanted to say something when you said you will not meddle with ostium too much. You are not going to meddle with the bone too much. You wanted to tell something. You can go ahead and tell. What is it you are trying to say?
Not consider for a radical procedure like a Calvin Dukes or something.
Radical is okay. No,
Caldwell look
tell
is
it in
outdated
simpler
for this.
terms.
Yes, no, it will affect the dentition. And also, no.
No,
Dentition.
if it is adult and recurrent antroconal polyp arising from the alveolar region, how will you remove? Recurrent antroconal polyp arising from the alveolar recess, how will you remove?
Recurrent antropoinal polyp. It is coming from the floor near the alveolar margin. Sir is saying.
Yes, sir.
Endoscopically, that's a difficult area to reach. So he is asking, how will you remove it?
Then,
What
Calvin
is
Duke.
pre-lacrimal approach?
Just now you said you should not do Caldwell look. We agreed.
No, sir.
What is pre-lacrimal approach? What is type 1, type 2, type 3? How will you measure? What will you measure? Find out. Okay. So, how will you, if there is a attachment is on the lateral wall, you can't remove it with the wide middle meatal anterostomy. How will you remove that? What instrument do you use to remove the polyp from the antrum? Endoscopically. What
Which
force?
instrument? You have to take it out. No.
Yes, sir.
Hugh-Weiser forceps. It's Hugh-Weiser forceps. H-E-U-W-I-S-E-R. Hugh-Weiser forceps. Okay, if you want to take it out with the debrider, what blade you will use?
Angled blade with blade inwards. Okay.
Rad 60 or Rad 1. If you don't reach it with the Rad 60, how will you reach then? You make an inferior meatus puncture and put your rad blade inside that, see it through the middle meatal anterostomy, find out where it's attached to on the lateral wall and remove it.
Yes.
Where will you do Caldwell surgery?
Calvin Dukes in adults, in recurrent antroconal polyps of adults.
No, which area?
Sublabially, sir. Sublabial incision is being given.
Sublabial is the incision. Where? Canine?
In the canine fossa, sir.
Boundaries of canine
fossa.
Yes, sir.
Boundaries of
boundaries.
Superiorly, sir, intraorbital margins.
Infraorbital nerve, not infraorbital margin. Infraorbital nerve superiorly.
Patient will have a severe neuralgia throughout the life if you go till the infraorbital margin.
Infraorbital nerve only.
Yeah. Yes. Alveolar ridge inferiorly, sir.
Okay.
Laterally the canine eminence and medially the piriform aperture.
Laterally canine eminence, sir.
See, piriform aperture is in nosma. Its incisor ridge medially. Okay.
Medially canine eminence, laterally small eminence or maxillary tuberosity. Okay, this is the area. Medially canine eminence, laterally maxillary tuberosity or smaller eminence, inferiorly alveolar ridge, superiorly infraorbital nerve. Tell me the indications for Caldwell surgery.
Indications, sir. Yes, sir. For recurrent antroconal polyps, sir, then closure of antroconal fistula, we can do.
Antroconal.
Or antral fistula, sir. Or antral fistula repair. Then, in case of excision of a dental cyst, which is extending into the maxillary sinus, sir, then cyst, then it can also be
blood fracture, blood fracture, orbital decompression, going through the pterygopalatine fossa.
We just had COVID-associated mucor outbreak. Isn't it?
mucormycosis. Okay.
Okay.
What
Which
is
are
it?
the
What
two
is when will you do
conditions?
calval look in a atrophic rhinitis patient?
What is Whitmark's operation?
Whitmark's operation.
Done in atrophic rhinitis.
Everything gets dried up, you know. You have
Yes,
to
sir,
lubricate
yes.
it. You lubricate it.
How your mouth gets lubricated?
What duct you will transposition into maxillary sinus?
Stensen's
Carotid
duct.
duct.
Isn't it?
Tensions.
Stensen's duct is brought and fixed into maxillary antrum. But that's the lousiest. I would never do it.
It's all theory
Because
question.
after
Then there's a
after all
surgery
the
called
effort,
Lawton's
Sir,
surgery.
honestly,
You got to do a
many
after all the effort,
surgeons,
you have an antrum filled with saliva, which can give
No.
smelling like anything.
all said and done, sir. Many surgeons
Yes,
say
sir.
as soon as they see atrophic rhinitis, simply
Uh-huh.
wash your nose morning and
Yeah.
night with saline. That is
Very
all
good.
they. Can
Yeah.
you tell me, maybe I think the time constraint, last two questions. Two
Mhm.
conditions which are both indications and complications of gallbladder luck.
One she has already told.
Two
Which one have
conditions.
you already told, Dr. Shaman?
One is below, one is above.
You have already told one.
You said choanal something.
Antroquinal polyps, recurrent antroquinal polyps.
No.
Oroandral fistula.
Oroandral fistula below, above.
That you have already told. Then
Fracture floor of the orbit. That also sir told. Francis sir told.
isn't it?
And one last question from me. Meningoencephalocele can be there. This is a trickish question. Kindly think and answer. Some amount of brain tissue is also herniating, you know. Suppose the
Yes,
hole is
sir.
small, how will you push it inside? How will you replace it? I gave you a clue. It's
The
a
part,
trickish- It's a trickish question.
Firstly, is it functioning brain?
Once it herniates out of the cranial cavity, it is no longer functioning brain. You won't replace it.
You don't push it inside. You just
You
bipolarize
won't
it.
push it bipolar. That should be the answer. Okay. You understood, Amma? Yes?
yes, sir.
Right.
Yes, sir.
Sir, yes, sir, any other question?
I have two questions for you. What is Canfield's operation? Can you hear me? Hello?
Madam, are you able to hear us?
I think she has already left the. By so
Yeah,
many
yeah.
questions.
We got vexed up our questioning, JP.
I know. Anyway.
Sahu,
Yeah.
Yeah, it was a nice
Sir,
session, sir.
good evening,
Thank
sir.
you for the
Sir,
Sir, good
spillover
evening,
of
1 minute,
questions.
sir.
Yeah.
Good
Sir,
evening.
this
Good
is
evening,
Dr.
sir.
Dr. Srinivas from
Yeah, yeah.
Tirupati, sir.
Shinu, good evening.
Nice meeting
Sir,
you,
good evening.
Good evening.
Sir, Dr. Azim, sir, good evening, sir. Dr.
Yeah,
Anthony,
good
sir,
evening.
good evening. So we are
Good evening.
very fortunate to have stalwart examiners like this, sir, on this platform.
No, nothing.
Because
Thank you. It's our pleasure.
all our PGs throughout Andhra Pradesh, they benefited by your presence.
Thank you, sir.
So
Thank you.
I am very much thankful to our AOIAP and also the organizers, sir, for giving this opportunity for our PG. She's exam going PG, but of course she's
Nice, okay.
she improved.
Thank
They
you,
will
sir.
improve.
Kumar, thank you, and JP also.
Yeah.
Yeah.
Sahu,
Thank you.
Yeah.
Sir.
just say some conclusion remarks.
Yes,
Then
sir.
I'll
Yes,
close
sir.
it.
Yes, sir. Yes, sir.
And
Okay, sir. Okay,
my honor to have been on this line with all of you people, sir. I enjoyed my evening. It was a
Thank you,
great
sir.
learning curve. We learned.
Same
To be
here,
frank.
sir. Even I enjoyed being here. It
Yeah,
was excellent being with all of you. And
Yes.
it was all the more nice seeing the youngsters present with enthusiasm.
Enthusiasm. Yeah, they presented with the real enthusiasm.
Very true.
Francis sir, good night, sir.
Good night. Good
Sir,
night, everyone.
Azim
That's
sir,
it.
good
Good
night.
night.
Nice being with you.
Good
on
night,
behalf of-
JP. Good night,
Sir,
Sinu. Good night, Kumar.
Thank
Sir,
you,
Good
JP.
night, sir.
behalf of-
Thank you.
Thank you.
Yeah.
Good
Sir,
night.
on
Good night.
behalf of APOI State Branch, I thank all the
Sir, good
three
evening.
examiners and I thank the postgraduates who prepared very well. And all, see, we have taken almost 30 minutes for each short case.
Yeah.
So that means 2 hours, full hours we have spent with the postgraduates, asking
Very true.
every aspect of the in any short case that can come. But
Yes,
the
sir.
discussion never ends. The question will
I know.
never end. We'll come
Yeah,
back
yeah,
to you with some more programs in the days to come. Thank you very
Sure.
much, all the examiners. And
Thank you, Dr. JP.
Sun
Nice
Pharma.
being with you.
Thank you, sir.
Thank you, sir.
Nice being
Good
with you,
night.
Dr.
Good night,
Durga
all.
Prasad, Dr.
Good night, Kumar.
Francis,
Sir.
Dr. Srinivas, Dr. Chaudhary.
So I
Thank
thank
you.
today eminent examiners, Dr. Durga Prasad sir, Dr. Ajim sir, Dr. Anthony sir, for a very impressive and informative discussion, guidance, and for making this evening very enriching in the terms of knowledge. And as well as my heartfelt thanks to all the delegates for attending today's webinar on behalf of Sun Pharma, makers of Cepodem and Montec FX, doctor. And I thank all eminent panel members for their valuable presence. Thanks to JP Reddy sir, Kumar Chaudhary sir for entire session wonderfully they're navigating. And I hope today's discussion ultimately benefits several patients. Thank you for giving us an opportunity. And as I mentioned at the beginning, we have planned series of webinar. Today completed 31st series of webinar. So very soon we'll be coming back with the next series of webinar of the series. Thank you, sir. Thanks for